Hello, everyone, and welcome to today's webinar. Today, we're going to talk about coronary revascularization in older patients, including left main PCI. My name is Alan Lewis, and I'm one of the non-invasive cardiologists, and I have the pleasure of being joined by my friend and colleague, Dr. Mandeep Singh, who is a professor of medicine here at Mayo Clinic. He's an interventional cardiologist, and he has a great interest in cardiology and cardiac treatments in the older patients. So thank you very much, Mandeep, for joining us and giving us this insightful webinar.
Thank you, Sushil. Today we'll talk about coronary revascularization in older patients. And it just makes me look into this beautiful statement from Claude Bernard, which says, "It is what we know already that often prevents us from learning." And that is so true in terms of revascularization in the elderly population. So with that background, which is the older patients are increasingly, that is a population that has increasing proportion of patients referred for complex PCI. This is a population which suffers from highest morbidity and mortality. And then when we risk assess these patients, they face so many implicit biases. And so the learning objective of this talk is to learn how to risk assess an older adult who is to undergo coronary revascularization. What are the procedural caution that we have to then observe, and then what are the lessons we learned from the trials that have been published on the revascularization in this population? Let's start with a case study, which is an 82 years old female who presented to our institution with a non-ST elevation myocardial infarction, had multiple morbidity, including kidney disease, diabetes, hypertension. She had low ejection fraction, hemoglobin was low, platelets were low, and then on inquiring, she did have a lot of difficulty in performing activities of daily living. In addition, she also had symptoms suggestive of congestive heart failure, and there was history forthcoming of atrial fibrillation, and she was on good regimen in terms of heart failure. So then how do we approach in terms of revascularization in this patient? So on your screen, you see the left coronary system exhibiting significant disease, both in the LAD and circumflex, and you can also see mitral annular calcification. For the right dominant circulation, the right system was had a minimal disease. So first thing we did when this patient came to us, she was hospitalized, was to calculate her procedural risk. And as you can see, we did calculate her procedural risk, which was not low. You can see that the mortality was in excess of 10%. Stroke risk was low, but then the acute kidney injury risk as well as the bleeding risk was pretty high. This was based off pre-procedural variables that we have in a study that we published in 2022 in Circulation. And I would then urge people to use objective risk models to calculate the procedural complexity and the outcomes that these patients will have, and not subject them to implicit biases. One of the other issues that we have to then uniquely address in patients who undergo PCI or stent placement is, in addition to the traditional cardiovascular risk factors, which then lose power as the patients get older, and then these GRACE scores, TIMI scores that are listed here, they actually put every patient who is to undergo PCI as a high-risk patient. Obviously, they can't distinguish what kind of myocardial infarction. So, for example, they can't distinguish type 1 from type 2. But in addition to the risk scores, then you have the physiological and hemodynamic data, which is so relevant. So, for example, patient is in cardiogenic shock, patient is unstable, patient has cardiac arrest, that kind of a thing. So that is the second pillar, in addition to the cardiovascular risk assessment. And then the third one, which we'll briefly touch about, are the anatomic and procedural risk. So, for example, bleeding risk is so high, and we'll address that. These patients have incredibly calcified arteries, and we have to modify our procedural tools in order to address that. But I think the most important thing is the last pillar, which is these patients have unique issues which then are linked to functional decline. And so most of these risk models that we have available to us do not address the variables that are linked to their functional decline. And so they do not estimate the biological age of this patient, which is so different from how old they are on paper. And so in addition to the cardiovascular risk, hemodynamic and physiological risk, anatomic and procedural considerations, I think we need to focus on the geriatric syndromes that these patients have. So this slide shows you some of these risks. So at the bare minimum, so this is, for example, the CV risk assessment. So we talked about the TIMI score, the GRACE score. On the other hand, we certainly can look into the clinical and the anatomic variables that put these patients at a high risk. But at a minimum, if we want to treat a patient who's older, we have to do their functional assessment. So we have to find out what they can do or can't do at home. So activities and instrumental activities of daily living, we have to ask what their goals of care are. If you want to then further target other geriatric assessment, social support is huge. So social networking, if they have or they don't, impact their prognosis and outcome. Frailty assessment, and linked to frailty are mobility and sarcopenia. We also need to then ask about and study objectively their cognitive impairment, depression, delirium, and then multimorbidity, as our patient had. She had diabetes, hypertension, chronic kidney disease. All these things matter in terms of their prognosis. We have to talk about polypharmacy and then common aging conditions. For example, incontinence, constipation, malnutrition. They look simple, they look obvious, but they are so powerful in terms of determining their long-term prognosis, especially if we want to estimate their biological age. And so that's what we did in this patient. So biological age, in contrast to chronological age, is just how the older adults decline from a functional perspective. And so we then, if I go back on this slide, we collected most of this information from a subset of patients who were undergoing angioplasty, older adults, and came up with the assessment of biological aging. And we made this Mayo Clinic integer risk score. Interestingly, when we filter down the 3 or 4 most important variables, we came across that older age. That makes sense. Older you are, more your biological age is. Second is functional difficulty. So for example, if patient is not able to maintain weight, is not mobile, is having trouble with continence, those are the patients who have more problems and higher biological age. More multimorbidity, so cardiovascular deficit. So we calculated everything and came up with a total score of 32 for this patient. And so the cause-specific mortality, so not only we can determine how this patient is going to die, so all-cause mortality, but we can also say whether the non-cardiovascular mortality, for example, in this patient, the 5-year all-cause mortality was 92%, And then when we filter it down to cardiovascular and non-cardiovascular, the odds for her to die from a cardiovascular mortality at 5 years was in excess of 50%, and non-cardiovascular was 30%. So these issues are relevant in terms of when we have a discussion, in terms of what do they want from the procedure. So it's not just putting in a stent, but then what are the goals that this patient has after we put in a stent? So the shared decision making is so very important. As cardiologists, especially who do intervention, we just focus on improvement in ischemia burden, put a stent and send this patient home. But ignoring the fact, what is the functional independence when this patient go home? What is the disposition? Where would they go? Would they go home or would they go to a long-term care facility? Are we improving their quality of life? How can we avoid social isolation? Amir Lerman did a fantastic study published last year on the importance of social networking. So it's very, very, very important. What are we doing in terms of preventing their falls and disability, improving their frailty? What are the challenges this patient has in terms of access to healthcare, follow-up? We can say, put a stent, come back and see a cardiologist in 7 days. Do we even know whether they have the means to come back to see a cardiologist? And not many patients, surprisingly or unsurprisingly, do not want to live longer, but they want to discuss whatever days I have left with, I need a better quality of life. So end of life goals need to be then discussed with the patient. So once we do these 4 pillars, patient has undergone or want to undergo this angioplasty, this is the first step we want to do, is to assemble a team of providers and nursing staff that then comprehensively address the issues that this patient has and come up with goals that align with the individual's goals of healthcare. Because every patient does not have the same goals, especially true for older adults. So lay out clear expectations for potential treatment benefits and risks, and then the trade-offs. So these are the 2 important things that I would say are very relevant in terms of coming up with a geriatric team approach, which is patient-centric. And when you look at the revascularization in older adults, the main issues besides their late presentation, shortness of breath, limitations of existing diagnostic tool, for example, more common type 2 myocardial infarction. Rajiv and Claire have done wonderful job in coming up that type 2 myocardial infarction is becoming more prevalent in comparison to type 1 MI, and this is more relevant in older adults. ECG is non-diagnostic. We already talked about their risk assessment. What I will delve next few minutes on is the drug-to-drug interaction, their higher Syntax score, which is a score or angiographic score based off of complexity and findings on coronary artery angiogram. How would we address what of the DAPT duration? So what kind of antiplatelet therapy will you give? For how long? And then how would you consider the post-discharge bleeding into the equation? Most patients, so the studies have mentioned about third angiographically, but if you look at from IV imaging perspective, most of these patients, 90% of males over 70 have coronary calcification. So why is that important? It is important because no matter how you look at coronary calcification, the outcomes are bad from an angioplasty perspective. So you can deliver a stent with difficulty, so you need more devices, more tools in your toolbox to deliver a stent. But look at the outcome data, which is 5-year outcome. The patient-oriented cardiovascular events, the target lesion failures, the cardiac mortality is 44% higher in these patients who have coronary calcification as compared to patients who do not. So those are relevant discussion points to have in these kind of patients who have lower procedural success because of excessive calcification, but also have problems down the road because their outcomes are not as good as a person whose arteries are not as densely calcified. These are some of the pharmacokinetics and pharmacodynamic issues that I brought up in the slide. So if you are older, you have lower GI motility and transit time. So even if you give Plavix to a patient who's coming with non-ST elevation myocardial infarction, that Plavix may be sitting in the stomach for a while, and you think it is absorbed, but then you are not giving any backup to improve the inhibition of P2Y12 receptors, and that may be a problem. The first pass to liver, that is decreased in these patients. The kidneys are not working, so you have higher incidence of acute kidney injury. You may not be able to give drugs that go and filter through the kidneys. You have problems with CYP2C19 enzymes, so their density is reduced in older patients, and so you have reduction in their phase 1 metabolism. So if you give clopidogrel, it may not get metabolized as quickly and as rapidly in patients who are older. So those are the considerations that are very relevant in these patients. So the pharmacotherapy considerations may impact your DAPT, sedatives, for example, the diphenhydramine and benzodiazepines in older adults have prolonged half-life. If patient has atrial fibrillation, they are at the highest bleed risk. So in these patient populations who are older, we have to strike a safe balance between patients' comfort and not letting them go into hemodynamic compromise because we are very aggressive with the pharmacology that we give at the time we put in a stent. So we calculated this patient's bleeding risk score, right? So this is one of the models. There are two models that are currently being used. So this is one of them. It's called Academic Research Consortium High Bleed Risk, or in short, ARC-HBR risk score. And so our patient had a risk of 4. Risk of 4 means major bleed, like almost kind of dying kind of bleed annually is more than 4%. And she has more than 1% risk of intracranial bleed. And this is determined by these variables. So if you look at these variables carefully, none of these variables are related to stent. And every variable is related to the patient. So older patient, renal disease, liver disease, cancer treatment, anemia, which this patient had, low platelet count, which this patient had, prior bleeding, stroke, need for oral anticoagulant, which this patient may have because of paroxysmal AFib. So all these things are relevant because if you put in a stent, how long will you give this DAPT for, and what kind of P2Y12 inhibitors will you choose? This is the comparison between the European guidelines and the American guidelines. I want you to focus on the high bleed risk patient because our older patients more likely than not have high bleed risk. And so in patients with acute coronary syndrome, which this patient had, we want to shorten the duration of dual antiplatelet therapy from traditional 12 months to 6 months. Now the studies are that you can get by just giving 1 to 3 months of dual antiplatelet therapy. So now if you already determined you want to shorten the duration of dual antiplatelet therapy, which of these P2Y12 inhibitors will you give? Now, there is a class 2A indications with the guidelines saying ticagrelor and prasugrel are preferred over clopidogrel if patient presents with ACS. Now, this patient that presents with ACS, now will you give ticagrelor, will you give prasugrel, or will you give clopidogrel because of high bleed risk? That's an important question. So this is a study of about 14,000 patients with acute myocardial infarction in a sweetheart study. It's just like registry data. But what they did was they looked at 1 year post AMI outcomes. And it's interesting from the Plato trial, which was, I think, 2007 or so, you can see an increased uptake of ticagrelor over time. In the span of 7 years, the ticagrelor was given to 0%. These are the patients who are 80 or above, to now 72%. So most patients who are discharged with a diagnosis of acute coronary syndrome, especially post-myocardial infarction, this registry data showed that the most elderly patients are being discharged on ticagrelor. But what is the data? Is it better than clopidogrel? And so they compared all these endpoints, and there was no difference in terms of their primary endpoint, which was death, MI, stroke. But look carefully, the death rates were higher in patients who were discharged on ticagrelor. The bleeding rates were higher, almost 50% higher as compared to clopidogrel. And that makes sense because ticagrelor is a more effective inhibitor of P2Y12 receptors. But on the flip side, the stroke rates were lower and the myocardial infarction rates were lower. So then you have what we call as a competing bleeding and ischemic risk. So you have to pick your battle in terms of which of these two agents you will give in combination with aspirin for 1 to 3 months after you put in a stent. So based on the data that this study showed, it was interesting. So on this side, we already talked about the ARC HBR, which this patient has pretty high one. Now on this slide, you have the thrombotic risk, which is related to the stent placement. So for example, she had left main LAD circ. So she will have a pretty complex PCI. So her thrombotic risk will be high. She has acute coronary syndrome presentation. She had diabetes, kidney disease. So her ischemic risk is high too. So what they did was, interestingly, in the accompanying editorial, they said, okay, so let's plot the bleeding risk on this axis and let's plot ischemic risk on this axis. If your bleeding risk is low, right? So if your bleeding risk is less than 4% and your ischemic risk is about 11%, then it makes sense for you to then use ticagrelor. But as the bleeding risk goes up, as in our patient, the ticagrelor lose that advantage over clopidogrel. So in patients who have high bleed risk, it makes sense for us to use clopidogrel instead of ticagrelor or prasugrel, because then you run the risk of higher bleeding and higher mortality, as was shown in this study. We came up with this, there's an excellent review article that came up in Mayo Proceedings this month by Brandon Ingram, where they said, okay, let's look at, this is a review article. If patient does not have any indication of anticoagulation, regardless of whether this patient presents with acute coronary syndrome or stable ischemic heart disease, but they have high bleeding risk, as our patient, it is immaterial. The presentation is immaterial. It is irrespective of the clinical presentation. You give dual antiplatelet therapy for 1 month. And then after that, you can continue on with clopidogrel, ticagrelor, or prasugrel. So regardless. So it is now much more simplified. And this is how the direction of the duration of DAPT is going, which is if you have high bleeding risk, you shorten the duration of dual antiplatelet therapy. And we talked about clopidogrel is preferred because this patient has pretty high bleeding risk, but you certainly can substitute that with ticagrelor if you think the thrombotic risk is extremely high. How about if I want to give her oral anticoagulant because she does have history of atrial fibrillation? So the practical approach is this. We give triple therapy, as Malcolm Bell says, triple threat, because it increases your bleeding risk only for the duration of the hospital stay. So you give DOAC or warfarin, but we prefer that you give DOAC. And because that lowers the risk of not only overall bleed, but also lowers the risk of intracranial bleed. So if patient needs DOAC because of atrial fibrillation, then you combine that with clopidogrel. That is the P2Y12 inhibitor of choice. And then you give that for a short period of time. If you have ACS and patient does not have any other bleeding risk, you can give clopidogrel for 12 months and then you stop. So for example, here, and then you stop and then patient continues only on DOAC. That's a default approach. So default approach is you give aspirin during the hospital stay, you give clopidogrel for 12 months, and then you give DOAC after 12 months. So DOAC plus clopidogrel for 12 months, that is the double therapy, triple therapy only for the hospital stay. And then clopidogrel, as I said, is the P2Y12 inhibitor of choice. The last segment I have for the talk is what are the latest findings, recommendations, studies that show what is the benefit of revascularization in patients who have stable ischemic heart disease. Now, if I draw back your attention to COURAGE trial, to Barry 2D trial, to Freedom trial, and then more recently to ischemia trial, the one message is consistent, which is none of these trials are positive in favor of stenting. All these trials have failed to show superiority of revascularization, especially percutaneously over medical therapy. The ischemia trial, now this is a study that was published just a couple of years ago, looked at the health status treatment difference. So that means the difference between if you put in a stent versus you manage them conservatively, right? Here you have patients who are younger, and here you have patients who are older. You can see that the SAQ, which is the health status questionnaire, how good your quality of life is much better in younger patients with stents or with revascularization. But as you get older, it comes back to the unity. So the treatment difference, for example, was 5 points in patients who were 55 years or younger, and it became only 2 or less, which was not significant difference between invasive and conservative as far as their improvement in health status is concerned. I also want to underscore that ischemia trial was negative, and there was no interaction between age and outcome. So older adults do not benefit in terms of not only improving their primary outcomes, which is death, stroke, cardiac arrest, and other outcomes studied in ischemia trial, but also their health status treatment difference was absent. But how about patients who present with acute coronary syndrome, as our patient did, right? So this is a senior RETA trial published just last year in New England Journal of Medicine. The largest trial to date of patients who are 75 years or older, 1,500 patients randomized 1-to-1 from invasive versus conservative treatment. No difference in terms of death from cardiovascular cause or non-fatal MI. The curves essentially overlap. There was some numerical difference in lowering the incidence of myocardial infarction. And so what they calculated was over a period of 5 years, you then invasive treatment, you have 29 additional days of freedom from cardiovascular death and non-fatal myocardial infarction. Now, there are some caveats, which is only 20% of eligible patients were enrolled. There was some delay in performing revascularization. They were lower risk patients, and only 30% of these patients underwent complete revascularization. Notwithstanding these limitations, I don't think it is a bad idea for these patients to be treated conservatively with medications that are guideline directed. So not all patients who have a lesion need to have a stent. And this trial totally exemplifies that statement. If you look at the age group, this is the subgroup analysis from the same study. Patients who are less than 80 did drive some benefit in terms of invasive management being better, but patients who get older than 80, there is essentially no benefit of invasive treatment over conservative treatment. These are the other smaller trials that have looked into the same comparison between invasive and conservative treatment in patients who have non-ST elevation myocardial infarction, and there is no difference. So none of these trials, including now the SENIOR-RETARD trial and the meta-analysis that came up after, has shown any benefit of invasive treatment over conservative treatment. But now if you pick up, now I'm not saying that all patients who are older need to be treated conservatively. There are subset of patients who would need percutaneous treatment. For example, if troponins are going up, patient is having chest pain, patient is having arrhythmias, or patient's wishes are that I want to get better, or their biological age is lower. All these patients should undergo angiogram and angioplasty. And the important thing is this FIRE trial suggested that if you take them to the cath lab, right? So these are the patients who present with myocardial infarction, the ST elevation in 35% and non-ST elevation in the rest. They did PCI and then physiological assessment of the non-culprit vessels. And what they found was, one finding was that 1 in 2, which look angiographically significant, they are functionally significant. So in other words, you can medically manage the other vessels that you think are significant. Based on this, I think I see two things. First, the death, MI, stroke, and ischemia-driven revascularization is much lower if you completely revascularize these patients. So do not leave the physiologically significant non-culprit vessels and treat them medically. So you treat them as if you are making all these lesions which are physiologically significant, treat them adequately with stents. If you do that, I think you have 36% lower cardiovascular death and myocardial infarction, and which is highly significant. 25% reduction in hazard ratio. So this is what I would do. I wouldn't take every patient who's older to cath lab, but patients who are taken to cath lab should be completely revascularized, as was shown in the FIRE trial. We did talk about the Syntax score. We did touch on the calcification issues. There are so many other procedural complexities, for example, these tortuosities that we as interventional consultants encounter, higher bleeding rates we talked about, and then the issue of cardiovascular support. For example, the danger shock trial, right? So in this one, it was significant in terms of lowering the death from any cause at 180 days if the patients are subjected to an Impella CP device. Now, if you look at the subgroup analysis, most of the benefit was driven in the younger patients. The older patients, again, do not drive the same kind of benefit. Maybe they have more complex disease. Maybe they have more complications from just delivery of Impella with high bleeding, acute kidney injury, and such. So we have to be careful in interpreting the results of these large trials and make it as if this is applicable across all age groups. So in the last slide I have this is, if the patient is then dismissed after a stent placement, it is very relevant, besides the shared decision making, to contact the pharmacist just to make sure that they are on all the guideline-directed medical management because they have multimorbidity. We then talk to, discuss, and rope in the family members, educate them in terms of their post-MI care. I don't think we can train them for CPR, but psychosocial support I think is very important. We talked about the social networking that is relevant, and then somebody has to bring them for cardiac rehab, and so that's very very relevant. And then finally, these patients need to follow up with one of us or any geriatrician or their primary care specialist. So the epilogue here is that we did a stent, which was successful, and she did go home on an abbreviated dose of DAPT for just for the hospital stay. So we discontinued aspirin at the time of dismissal. She was on apixaban and clopidogrel, and the clopidogrel we stopped actually at 3 months, and then she continued on apixaban after, and she's doing well. I thank you for your attention. So this is just the summary of it, which is we want to make shared decision making with the patient and the family. Patient-centered determinants are very relevant. These patients come up with very complex and multivessel disease. The PCI, we realize that doesn't improve survival, even in patients with non-ST elevation myocardial infarction. If we choose to stent, we do a complete revascularization. And then the risk and calculation of post-discharge bleeding and ischemic risk should dictate the choice and duration of dual antiplatelet therapy. Thank you.
Thank you very much, Dr. Singh, for that great talk. I invite the audience to please type in your questions into the Q&A function, and we'll answer them here. One of the questions that comes in really relates to that question of ischemia and COURAGE trials. Mandeep, you have an older patient that comes and sees you in clinic with stable ischemic heart disease. When you're in the clinic room consulting with them, how do you decide whether you're going to choose a conservative strategy or to take them to the cath lab and have a look and see at the arteries?
Right. So if you look at the COURAGE trial, so the ischemia trial actually stemmed from the finding from the COURAGE trial, which suggested that patients who have more than 10% myocardium at risk did benefit from a more invasive approach. And then that's what they made their denominator as, or the cutoff in ischemia trial, that they wanted patients who have such a large area of ischemia to come and get randomized. But they didn't find any difference. So it may just be that it's not just the ischemia, but the other issues that are very relevant, especially in older adults. So 15% of ischemia trial patients were older than 75. They did not find any difference, as they did not in the younger population, of any benefit. They did find benefit in the younger population in terms of improvement in quality of life, but in the older population there was none. I would say that if you practice according to the ischemia trial, I definitely would want everything I said in terms of calculation of their risks, shared decision making, their goals. But I also, think that it is relevant for us not to miss, for example, left main. We worry that this patient has a left main disease. So CT is very, very important in the decision-making process. Unless the patient wants to bypass the CT scan, it does involve contrast. But that would be something that you may want to rule out before you start treating these patients medically, that you are not looking at prox-LAD, left main disease that you are missing, and then you're treating them with medical therapy where revascularization clearly has shown superiority of medical management.
So sort of the patient in your clinic room, talk with them, decide what they want, talked about the risk, calculate the bleeding risks and things like that.
I would definitely do that, yes.
And then, as you sort of mentioned, put all that together, then rule out left main disease, and then sort of medical management is
right. I mean, if it is distal OM, right, I certainly can manage medically, and then the decision to move ahead with PCI or angiogram rests on not so much on the stress test finding, but on the patient. So if patient continue to have symptoms, EF is depressed, patient is a diabetic, I have a high probability of finding left main three vessel disease. I would certainly take this patient in a heartbeat for an angiogram.
That makes a lot of sense and very pragmatic there.
Right.
Can I ask, when it comes to revascularization choice, especially in the older patient, how do you decide stenting versus surgery? Is there any particular thoughts or advice that you have there for our audience?
Right. So my approach is pretty simple. So I follow the guideline in terms of which patients would go for surgery regardless of their age. So we send, for example, if patient has a distal left main bifurcation disease, has high syntax score, highly calcified vessel, has chronic total occlusions, we send these patients for a surgical opinion, especially if they have depressed ejection fraction, especially if they're diabetic. So the trials that I quoted clearly showed superiority of surgery over angioplasty. So, for example, the syntax, if your syntax score is more than 33, if you have a left main disease, if you have PROX-LAD, if you're diabetic, if you're depressed EF, those are the kind of patients who definitely will benefit from surgery. Now, we send them for surgery, and then if they do not want to operate because of patients, they are unwilling, or they're so high risk that surgeons don't think they will come out of bypass, then they are referred back to us, and then we perform a very high risk PCI after informing them that this is not the best and the first choice, but we have to do something because of their symptoms or depressed ejection fraction. So that's what we do in our real practice.
That makes a lot of sense. We encourage the audience to keep sending in your questions here. Another question that often comes up is the type 2 MI patients. You mentioned that they're becoming more and more frequent. How extensively do you investigate and how do you typically manage them is one of the questions from the audience here.
Yeah, so type 2 is much more than type 1. So there is a paper I often quote, and viewers can look into. I think the last author is Morrow. It came in circulation 3-4 years ago, and it exemplifies in a very nice fashion type 1, type 2 MI. If you have, I look at 3 or 4 variables if I make a diagnosis of type 1 versus type 2. So type 1, we say patient has typical ischemic symptoms, which are prolonged, right? Especially with ST elevation, especially if they have large delta in their troponin, especially if their troponin is in thousands. So don't think that this is a type 2 MI and you're sitting on a patient who is writhing in pain and his troponin is 2000. That's not type 2 MI, even when patient has anemia or any other feature that you can blame type 2 MI for. But this patient is having a type 1 MI. On the other hand, if patient has just had a surgery, we've seen patients in CCU or ICU setting had a major issue. Their troponins are either flat or just mildly elevated, and you have an explanation why this patient's troponins are elevated, which are modest. Then we don't pursue, and we certainly can do an echocardiogram, but that distinction of symptoms, large increase in troponin, very high troponin absolute values, point you to a type 1 versus type 2. If you have a type 2, you just take care of the condition and don't take the patient for an angiogram.
That makes a lot of sense. Another question that often comes up is sometimes you have a patient, they choose to be DNR, DNI, but then they say, okay, well, I do want an angiogram. And we all know that catheterization has a high risk of ventricular arrhythmias just by the nature of what we do. How do you deal with those patients, or how do you counsel those patients? What do you tell them?
Yeah, I think that's an important question because first of all, if patient doesn't rescind their advance directive, we don't do an angiogram. There's no way I can guarantee nothing's going to happen. So if there's a change of heart from a patient's perspective, from a conservative to now becoming more aggressive, they have to change their advance directive. So that's first thing we ask them, that if you are coming on board in terms of getting the angiogram and stent, yeah, it's 90. Now, for this patient, for example, the mortality was 11%. So there's 89%. So if you're an optimist, there's a 89% chance you're going to live. But then if you are a relative risk, if I do your stent, your risk is not even 0.5% of mortality. But then I say your risk now is 10%. That's 20-fold of a low risk patient. And then you say, oh my God, my risk is so high. How do I reconcile? I think it's from a patient to patient, but we have to go, and we do go and talk to the patient and the family before they rescind their advance directive and before they take us, before we take them to cath lab.
That makes sense. And I guess there's a group of patients that say, yes, I'm fine to reverse my DNR, DNI for the procedure, and then afterwards can I have my DNR, DNI back?
We do that. We do that all the time. Once they get the stent done and they're doing okay, they go back to, because what we have determined, and that paper came out, I think 3 years ago in Circulation, most of the adverse events after the stent placement in most patients happen within first few hours. If they go by in 1 day, 2 days without any adverse events, the likelihood of them to get into trouble from a stent perspective is almost negligible.
So sort of short duration after procedure is the biggest risk.
Oh yeah, for sure.
And then,
I mean, stent thrombosis, bleed, arrhythmia, you name it, and that can happen. But we are getting better in terms of doing radial PCIs in almost all of us. We hardly use femoral other than if we need a large bore access. The stents are getting better. We have now second generation stents. The stent thrombosis rates in the first year is 0.7%, and then 0.2% after. So it's very, very low stent thrombosis risk. We use IV imaging now much better in terms of procedural planning and optimization of results. That has gone up from 4 or 5% to almost 50% plus. But then on the flip side, the patients are becoming more complex. So as you mentioned, what happened to this patient who goes for surgery, but surgeons deny or patient doesn't want surgery, they come back to us. So those are patients who are extremely high risk from our perspective. And I would encourage people to start using risk calculators. Those are our friends and not foes. And then use tools. And that paper is coming out in JAHA for biological aging, because that is a different, totally different concept, which will make you decide differently. So if, for example, if I do a 80-year-old, the biological age is 92, I don't want to do a stent, and there's no prolongation of life here. It's just the quality of life we are talking about. But I think if you bring those concepts to the patient and the family, they are very relevant. I think that will resonate with them, and they will make a decision which may be different than what you initially intended to, which is putting in a stent.
Mm-hmm. You said something earlier in your talk that was, sort of a little bit earth-shattering for those of us when we were training. We were all told, okay, non-STEMI, take them to cath lab, put some stents in and reopen them. And the data there was really quite striking that, we may not be making a big difference similar to a stable patient.
Right. So the Seniorita trial, it just came out like 4 or 5 months ago. It was an eye opener. We may or may not believe in it, but that's the data. We have 1,500 patients, and the thing that they did differently than the other trials, they included patients who were frail. So 34% of patients in the Seniorita trial were frail. The average comorbidity was 5. Then they have, I think 60 or 70% had cognitive impairment. So this is a real time and real world issue for us in how to then deal with these patients who are frail, who have multimorbidity and cognitively impaired. Will you take them to the cath lab? They did. And that's why maybe that they could enroll 1 out of every 5 screened, because either other 4 did not want to, or something other thing happened. But then this is a real world experience of patients who are 75 year older, who are frail, who are cognitively impaired. You put a stent, and 90% plus in their study, they had stents, and very small subgroup had a bypass surgery. So it's mainly we are talking about stents. But then their long-term 5-year outcome is not different. The invasive treatment was better for a year or two, but the curves crossed at 2 years, and at the end of 5 years, they're numerically equal. So we have to then, I think, sub-select amongst those non-STEMI patients, which of these patients will benefit from our aggressive approach. Not everyone. We have to then select some of these patients based off maybe symptoms, based off troponin, based off of LV function, their diabetic status, and what have you. But we have to be very selective in choosing the right patient. But not all non-STEMI elderly will benefit from a stent.
Do you have any preliminary thoughts based on the data available as to who we should be offering stents to in the elderly population presenting with a non-STEMI, or very individualized decisions?
I think that's where all the things, the pillars, the shared decision making, the biological age calculation, the Mayo Clinic PCI risk score calculation, they all are so relevant. And then you are absolutely right. It has to be individualized, and not like if you have non-ST elevation, let's do your stent. That's not how it is. It is different with the ST elevation MI, that we still, I think, are very aggressive in stenting in a timely fashion. But non-STMI, unstable, is a wide spectrum. It's a very heterogeneous population. It doesn't mean that if you think patient has ACS, they should go to the cath lab and put in a stent. That paradigm has totally changed and shifted. And so it begs the question that out of all these patients who are presenting with non-ST elevation MI, which of these patients will benefit the most from very aggressive revascularization efforts? I don't know the answer to that, but I do know that all these efforts towards calculating, addressing their geriatric syndromes, having a shared decision making in terms of asking patient what their goals are in life, and then not all angiograms are equal. So some may have just a straightforward mid-LED discrete lesion, which is very less likely. But most of them will have horrendous disease that you would think twice before you start exploring putting in a stent. Sometimes we take the patients off the table and say, gee, we don't want to do it. And then we have a rediscussion with the patient, and they say, no, I want to get it done. You bring the patient back and put a stent at a much higher risk because we didn't like what we saw in the first place when we did the angiogram.
Thank you very much. We have one more question here. how do you treat the elderly patient with ACS conservatively? What is your approach? DAPT for how long? Need for anticoagulation? Sort of what's your approach here if you're medically managing
Right,
an
right.
ACS patient?
So I think the medical treatment is very clearly outlined in all the guidelines. So um, if I have to make one plea, that would be for bringing their LDL as low as I can, right? I mean that will prevent future events. So I would say I will bring the LDL to 55 or below, right? So that will be one thing I would do. From a ischemia perspective, certainly beta blockers, if they are candidates for long-term beta blockers with or without other anti-anginals. So that would be from the angina perspective. From the DAPT perspective, um, the medical management patients should be treated exactly as the PCI treated patients. Um, in terms of their ischemic risk and their bleeding risk. There is a study, it's called ARC HBR trade-off study. And that's a beautiful study in the sense that it gives you both ischemic and bleeding risk, similar to the DAPT, what is it, DAPT trial. It had um, uh, there are 5 or 6 variables that gives you whether you should continue DAPT after 12 months or not. Similar to that, ARC-HBR trade-off gives you whether you should continue DAPT for a longer period of time or not. But I think out of 2, and those studies are also available, that out of 2, surprisingly, bleeding risk is much more meaningful in terms of being a prognostic harbinger as compared to ischemic risk. That's surprising, but that's true. So if patient has both high thrombotic or high ischemic and high bleeding risk, one, both have the same hazard ratio in terms of their prognostic significance. So if patient has high bleeding risk, high thrombotic, don't ignore bleeding risk. So that's one thing. There are studies that are available that suggest that bleeding risk trumps the ischemic risk in terms of choosing the duration of DAPT. So if you have, for example, this patient had a ARC HBR score of 4, this patient is certainly going to bleed on a DAPT. And so you have, even if medically managed, put a stent, doesn't matter, you want to shorten, you want to abbreviate the duration of DAPT from a traditional 12 months, by guideline 6 months, but I would argue you can discontinue and should discontinue aspirin even sooner. Because if you continue to pile up the DAPT, which is unguided, you will run into trouble. Because once this patient starts bleeding, you will stop the P2Y12 as well. And that is when the rebound coagulation and thrombosis happens, and this patient can get into a lot of trouble.
That's great. So just to summarize for our audience member here, let's see whether I've got it right. So DAPT in all the patients with duration based on bleeding risk, guided duration, guided also by that bleeding risk. You may want to shorten it in your high-risk population. You want anti-anginal therapies, predominantly beta blockers if they can tolerate it, but then you can also use the rate-controlling calcium channel blockers or a nitrate if you need additional anti-anginal therapy.
Absolutely.
We'd usually heparinize them for 48 hours while they're in hospital. No. So wouldn't heparinize them.
If medically managed, yeah, you can. But no, I mean, when we take them to the cath lab, they are not on heparin anymore.
And then I guess statin therapy and other lipid lowering therapy to bring that LDL as low as physically possible.
I would definitely, and then cardiac rehab. Those kind of things are very, very important. Drug to drug interaction, pharmacy, cardiac rehab, they should fall. Those kind of things are very, very relevant. The other thing which we may not have time, maybe may have a minute or so, is we've started doing genotyping. So you realize 30% of patients who are on clopidogrel have CYP2C19 polymorphism, and they may not metabolize that drug as well as ticagrelor, which does not require liver metabolism. So what we have started doing is in high ischemic risk patients, high thrombotic risk patients, we want to make sure before we drop aspirin, they are metabolizing their clopidogrel. So we are then doing CYP2C19 genotyping on that.
That sounds good. I think we're right up against time here. So thank you very much, Dr. Singh, for a great webinar here. Thank you very much to all of you in the audience for joining us in the great discussion that we've had. And we look forward to joining you for the next webinar.
Thanks, Sushil.